conference like this, and I'm delighted to be here to speak to you today about diabetes as well as age-related macular degeneration. I have a little bit of a cold, and I'm sorry because I sound kind of hoarse, but I'll try to do my very best, and if you can't hear me clearly, let me know. So I just wanted to start with something a little bit light. This is actually me when I was biking through Europe, and I happened to run across this really cool sculpture. As you can see, it's a big pair of glasses. And I really liked it. I thought it was kind of a metaphor for this lecture, because we're going to be looking out over the horizon of new treatments for diabetes and macular degeneration. And I like the idea that, you know, we're all here to save our vision, to make sure that we live healthy lives and have good vision for our entire lives. Because there's a big world out there, and we want to look at it. We want to see it and enjoy it. And we need a good vision for that. Plus, sometimes there's so much to see, you need a big pair of glasses, right? So, diabetes in our country is very frightening because it's extremely common. And you can see the other thing that's really, really interesting is that it's increasing as the years go by. So there's something about our lifestyles and our diets that are really hurting us and creating this problem. And as you can see from this slide, there are clusters of areas where diabetes is even more common, and those are the really dark red areas that you see. And all these areas are increasing. So at one point, if you looked at this map 20 years ago, it wouldn't have been nearly as red, it would have been much more yellow. But eventually it looks like the whole United States might be in this dark red color, which indicates a very high prevalence of this disease. And what we know about diabetes is that it doesn't affect everybody equally. It seems that there are clusters, again, where our American Indian population, it's very, very prevalent. Non-Hispanic blacks, it's very, very prevalent. Hispanics, we see quite a bit of it. Asian Americans and non-Hispanic whites are the lowest, which is good, but we still have to be very aware of this disease. So, type 1 diabetes. When we talk about diabetes, we talk about type 1 and type 2. I don't know if anybody's familiar with that. And so the thing about type 1 is it tends to be diagnosed earlier. Sometimes it can be diagnosed by age 2 or even earlier than that. And these are patients that are not making insulin. They just stopped. Their beta cells in their pancreas stopped making insulin. And so they're on insulin replacement, namely insulin. And most people have type 2 in our country. So this makes up about 10% of the patients with diabetes. And of course their blood sugar is elevated. And we feel that this is an autoimmune disease where somehow something within the body is attacking the beta cells in the pancreas. It is familial. It runs in families. We haven't sorted that out so well, and we haven't been able to do too much with this knowledge. But these are some of the genes that are associated with it. So yes, as I was saying, there are cells in the pancreas called beta cells that create the insulin. And in a normal islet cell in the pancreas, this is what we see. But with type 1, these beta cells are destroyed and insulin is no longer made and must be replaced. And again, as I was saying, it definitely runs in families, but we need to sort this out a little bit more and develop strategies based on the genes. Now, type 2 is more complex, and type 2 involves all these different organ systems. And with type 2, there's insulin resistance. So you may be making some insulin, but your body isn't absorbing it correctly. And sometimes this is associated with obesity. And so sometimes it can be controlled with diet and exercise, and maybe some medication. But sometimes you need quite a bit of medication you can't control with your diet, and you may even need insulin. So some people thought that, you know, if you take insulin, you're automatically a type 1. That's not true. You can be a type 2 and require insulin as well. So what happens to the body when we have diabetes? Well, first of all, it's a systemic disease. So I know that if I find diabetic retinopathy, I know that other organs will be involved in the body. I know that, it's a fact. So those patients that I diagnose this with will have kidney disease, and they will have neuropathy, and they will have all these different problems. And I think some of these numbers are really staggering. I really like looking at this because it shows you how diabetics suffer from so many different problems. Diabetic neuropathy, 60 to 70% of the patients will have this. So these are really common. And not only does it affect the tiny little blood vessels, so of course the retina is in danger, but also larger vessels. So these patients have a higher risk of coronary heart disease and stroke. So these patients need a lot of medical care. They need to see not just their ophthalmologist, but often they need to see neurology and a cardiologist and follow it for all these different issues that we have. Now I think we have to start with the basic, what's inside the eye. And let's start at the very beginning. And it's kind of important to know the anatomy. A lot of my patients will try to describe something and they'll describe it all wrong. So it's good to know this. So this is the cornea, which is the clear covering on the outside of the eye. And then what surrounds it, the white part, is called conjunctiva. And the layer behind the conjunctiva is the scleral shell. It's like a nice shell. And then when we dig a little deeper, we have the anterior chamber right here, and that's full of aqueous. And then right here is the lens. Okay, so if you have cataract surgery, we go in, we make a little incision here in the cornea, and then we go in with ultrasound and we remove the lens. But we leave the very back layer on, which is called the posterior capsule, because you can see it's suspended by these little zonules to the ciliary body. And we put the implant right in this little bag. So we kind of carve out the lens that's opacified, and we stick the little implant right in. So it's held in place by the zonules. And then when we go deeper, we get into the vitreous, and that's the jelly in the back of the eye. And some of you may have floaters. That's usually from the vitreous, okay? And then we go a little deeper, and the first layer of tissue here is the retina. It's very, very thin. It's like a piece of silk, okay? That's how thick it is. And it's about the size of a quarter. And that's what I've devoted my life to. Can you imagine? Preparing this. So everything I do is microscopic, which I love, and very interesting. But we do rely on quite a bit of imaging so we can figure out what's happening to your retina. And then we go a little deeper. We have the retinal pigment epithelium, which is very important in diseases like macular degeneration. We can talk about that a little bit later. And then we get back to the choroid, which is a vascular tissue that helps supply nutrients to the retina. And then we're back to the sclera. And then the optic nerve takes all this information from the retina and takes it to the brain where it's decoded as vision. So it's really amazing what happens in our eye, right? It's this little organ, but there's a lot going on. And so this is how it looks when we examine it. And it's actually a really pretty color. It is this orange color. So this is an Optos, which is a wide-angle camera. You may have had pictures done at your ophthalmologist's office. And here's, we're kind of like looking through, and here's the iris. And we're looking behind the lens into the retina. And you can see the optic nerve and the blood vessels. Excuse me. The larger blood vessels are veins, and the thinner ones are arteries. So there's arteries going in to bring nutrients, and the veins take the blood away from the eye. Okay, so what happens in diabetes and how does it affect the eye? Well, the very first thing we see is non-proliferative diabetic retinopathy. And with non-proliferative diabetic retinopathy, there are two things that can happen. We can see tiny little hemorrhages throughout the retina. And some of these hemorrhages are associated with abnormal blood vessel formation, and some of it is associated with leakage. Well, we can also see edema in the macula. And what I mean by edema is thickening. So sometimes you can have loss of vision from little blood, but sometimes you can have it from edema, which is the liquid part of the blood that oozes out. And this can obviously cause a reduction in vision and blurring. We do a lot of imaging, so if you've been to the retina specialist, you may have had some of these tests, fluorescein angiography, OCT, and fundus photos. And we see really interesting things that happen. Some of it is the eye is actually trying to repair itself. Excuse me. I really have this horrible cough. And we can see that there are these little microaneurysms, and those are little outpouchings of the vessels. So the tiny little vessels get damaged, and they start to form these little microaneurysms, and they're very leaky, and they leave blood and edema. And then, so we can pick this up in our pictures, and sometimes they'll also leak this yellow stuff, which is actually fat. So it's like a lipoprotein that gets deposited in the retina, and that can really, really upset the vision because you really can't see through that at all. So all this tissue is so important for vision. And so when you have anything that blocks it, blood, edema, hard exudates, you start to lose vision. And then what happens after this is what we have is an ischemic setting. In other words, there's not enough oxygen going to the eye, and that's a problem. As this gets worse, we start to see abnormal blood vessels growing out of the retina and into the vitreous. So it's almost like abnormal vines growing all over the place. And these are very fragile, and they bleed and they ooze, and this leads to huge problems where you can have the whole eye full of blood. And so we have to treat this pretty aggressively. So this is just, again, most of you have probably been to a retina specialist, I think, probably. So these are some of the studies they're going to get, and I want to explain this so that you can understand, because it's not hard to understand. So when you look at the picture, this is actually a slice, like if you take a slice of a piece of cake, and if you think of the cake as the retina, you're slicing through, and you're looking at it this way. And so you can actually image all the different layers of the retina. I mean, how unbelievable is that? And we can do it in a split second. You get all these images, it doesn't hurt you at all, you just put your head in the machine, and quickly we obtain these images that we can show you right away and make a diagnosis right away. I mean, the technology is unbelievable. So here again, we see all the different layers of the retina, and it's supposed to be nice and smooth, very distinct layers, like a 9-layer, cake. But here you can see these layers are not well defined, and in fact, we see these big bubbles, which are cysts, and that is the edema. So you can see it really readily here. And this is the macula, and the macula is part of the retina, but it's a subdivision of the retina that gives you really, really good vision. Okay, so a lot of times we talk about macular disease, and what that is that subdivision of the retina that gives you your reading and your driving vision. It's small, it's not a big area of the eye, but it's the most important part of the eye because that's what we really care about, right? We want to read and drive. So again, most of you will have, or maybe some of you have had fluorescein angiography, and this is an easy test. We do it right in the office. We inject a dye, and it's a very safe dye. It's a vegetable dye called fluorescein into the vein, and then we do serial pictures. And we can actually see the vasculature of the retina. So we can see the arteries fill, and then we can see the venules drain the blood out, and then we can actually see all this abnormal anatomy. And it's very, very interesting. Look at this. These are the microaneurysms, and they almost look like, I always think they look like stars in the sky at night, like a constellation. And you can see how they're leaky. So the dye actually shows us which ones are really leaky and how much. So like this is a very big one, and you can see how it's leaking all this fluid. So this is a problem. And we like to know this because we can concentrate our treatment right on the most leaky microaneurysms. We use this as a map if we're doing laser. So DME, which is diabetic macular edema, is seen in about 30% of patients with diabetes for 20 years. And we used to only do laser, we only had laser, but then as time went on, we actually started to develop other drugs to treat this, which are right now pretty much the anti-VEGF drugs and steroids. And these have really helped in our treatment. And now most retina specialists will use a combination of treatment. And so for those of you who have been treated, some of you probably have received a little laser and some injections into the eye. And even though the injections sound terrible, as you know from Larry, they're not that bad. We do them right in the office. It takes me about 5 seconds to do it. It's very quick, and the patients do really well. The risk with it is very small. So who are the patients that get diabetic macular edema? Well, I'll tell you, hemoglobin A1C really helps us figure out who that is. And this is a very interesting statistic here, because for every 1% increase in hemoglobin A1C over the normal level, there's a 50% increase in diabetic macular edema. So if you come in and you say, well, you know, my hemoglobin A1C was 10, but I got it down to 8, and that's great. That is great, but you're still at high risk for developing diabetic macular edema. So we really want it to be 6 or below, which it might be impossible for some diabetics, but that's kind of the gold standard. Okay, and there are other things that increase your risk of diabetic edema. Almost anything will increase your risk of diabetic edema. If you have problems with your teeth, if you're suffering from cancer, if you have a cold, uncontrolled hypertension, hyperlipidemia, all these things will increase the risk of leakage from these abnormal blood vessels. So when we approach patients with diabetes, we really have to, it's very multifactorial. We have to think of the whole body, not just the eye. And inflammation plays, a huge role in this. And so we're always thinking about reducing inflammation, because inflammation causes these blood vessels to leak. And this is kind of a complex slide, as you can see, but there are many factors involved. The point is there are many factors that are involved in this process. And as we become more sophisticated with our research, we're hoping to maybe block some of these little proteins and try to control the diabetes in a different manner than what we presently are. One of the most important molecules that causes this inflammation and this leakage is VEGF, vascular endothelial growth factor. So many of the drugs are geared towards blocking VEGF. And again, it's very complex as to why this happens, and maybe you're not so interested in this, because now we're really talking about cellular things that are happening within the body. But basically, we lose a supportive cell around the vessel, which is called a pericyte, and this leads to endothelial cell death, and this leads to breakdown of the inner and the outer retinal blood barriers and loss of tight junctions, thickening of the basement. All this stuff is going on, which eventually leads to vascular leakage. And then there's also oxidative stress. So we have damage to macromolecules, cytotoxicity, and we get all these different metabolic paths going that are very damaging to the eye and to the rest of the body. So it's complex. There's neuronal degeneration, glial proliferation, which is abnormal scar tissue growing in advanced cases, loss of photoreceptors, which are the little cells that actually help you see. There's vascular damage, which leads to ischemia or lack of good oxygen to the tissue. And then also there's this mechanical thing that goes on where as the disease gets really bad and we see abnormal blood vessels growing into the vitreous will start to pull on the blood vessels and tease them even more and make them bleed. And so that can cause this mechanical situation which will also cause additional bleeding. So VEGF has become really an important molecule in a lot of diseases. What's interesting about medicine is there's a lot of overlap. So VEGF plays a role in many diseases, but in the eye, we're particularly interested in what it does for macular degeneration, retinal vein occlusion, and diabetic macular edema. And these anti-VEGF drugs play a huge role in treating not just diabetes, but all these different diseases. So you may say, well, if VEGF is a bad molecule, why do we have it in the body? Well, I always say a little is good. Like a little wine is good, a little glass of wine is good, but a lot of wine is not good. And that's what happens in these disease states. We have an overabundance of this molecule that's causing quite a bit of damage. So the idea with these drugs is to soak it up and remove it so we don't have this molecule around that's causing all this damage. But we do need a little bit of it because it helps us with growth and development as an infant. It helps us with repair of tissue when we have a sore or a broken bone or something like that. It's very involved in wound healing. So we need a little bit of VEGF in our bodies, and that's why our bodies need a little bit. But in these disease states, it goes haywire, and all of a sudden we have way too much all around the body. We are very fortunate to have quite a bit of treatment for diabetic macular edema and proliferative diabetic retinopathy. And this includes Avastin, Lucentis, and Eylea. Those are our anti-VEGF drugs that are currently being used for the treatment of this disease. We also have laser, as I stated before, and we have steroids. Steroids can help many disease states. We don't want to give a lot of steroids because it can cause damage in other ways, but a little steroid can really calm down these eyes and really help with the vision. And we have a few steroids, and again, you may have been treated with some of these, and if you have specific questions, you can ask me later. We have triestins, ozurdex, and Iluvien. Now, Iluvien is really cool. This was the most recent that was FDA approved, and it actually is a little tiny pellet that we inject in the eye, and it lasts 3 years. So some of my patients who I've basically thrown the kitchen sink at and I've had to do laser and injections, all these different things, I've been finally able to control them with this Iluvien, which is a slow release of steroids. And it's really interesting. It's not for everybody. You have to screen the patients pretty carefully. But again, you can talk to me later if you want about this. And then sometimes we have to move on to surgery. Either we catch the patients too late, which is why it's so important to get screening early on. Because when you, a lot of my patients say, well, I don't have any symptoms, you know. That's when we want to start to treat, before you start to lose vision. Because once you start to lose vision, I have to work really hard to get you back. And I may not be able to. So we want to catch the disease at its earliest stage, okay? So that's why, excuse me, what we recommend for type 1s is to get an eye exam right away. And actually, with type 1s, we like to see them 5 years after their diagnosis, and type 2s we like to see right away. Many type 2 diabetics have been walking around years undiagnosed. And so we know that we're kind of already behind, and we want to see these patients right away. So a lot of my patients will say, well, I don't know why I'm getting all this treatment because I see fine. Yes, but I can pick up all this damage with all my, my exams and my imaging, and that's when we start to treat. However, if some patients come in late or they have very complex disease, and sometimes, like I said before, the eye can fill up with blood or there can be a lot of scar tissue, and then we actually go in and do vitrectomy surgery. And it's a very beautiful surgery. I love doing it, but we don't want you to be in that boat, so that's why we're encouraging you to get to your ophthalmologist early. And we use tiny, tiny little instruments. They're 25 gauge. And I have all these little instruments that I can put in the eye. Some of them are like a little vacuum cleaner where I can cut and aspirate and vacuum the blood out, so it's really cool. Some of them are little tiny scissors, so I can actually cut away the membranes. And I use my 2 hands and my 2 feet, and I'm looking through the scope. So the patient's laying supine, the scope is over their head. And then I have instruments in each hand. In one, I have a light, a little flashlight that I put in the eye so I can see everything really nicely. And in the other hand, I'm using all these little special tools, including a little instrument with a little laser on it so I can laser more and cauterize the little blood vessels that are bleeding. Excuse me. Okay, so moving right along. So in case you're interested in what these, how the anti-VEGF drugs work, they're actually, this is a biologic. It's an antibody made to the VEGF molecule. And so it actually goes in and soaks up the VEGF, or it blocks the VEGF receptor, depending on which drug it is. So it's a very unique way of doing this. And what we have found is that in these patients, this was a study that I actually participated in, Rise and Ride, and this was through Genentech. This is for Lucentis, and all these drugs are very well studied, so you don't have to worry about that. To get anything FDA approved in the United States requires quite a bit of clinical trial. So, and you can see here that this made a huge difference in outcomes, and these patients had a huge improvement in their vision with reduction of edema. And this is, when we do these studies, we always have to have some sort of a control arm to make sure that our drug is really working. And this is when we compared it to standard of care, which happened to be laser, and the injections. These are the number of letters that they picked up. So when we do the eye chart, we're talking about the Snellen acuity, and we have a way of doing this where every letter you get gets you a point. So when you're reading down the eye chart, if we see an improvement of 10 letters, which is great, that's like over 2 lines of improvement, that's a great outcome. And these patients that were treated with the anti-VEGF, this was Lucentis, picked up all these lines of vision, whereas the people who did not get treated just picked up a little bit. So you can see, even though the thought of an eye injection may be quite disturbing to you, you can see it's so necessary, because if you want to see better, you get your eye injection. That's the way it is, okay? And it is actually very easy. The most you feel is like a little mosquito bite. I always say the most you're going to feel is like me pulling a hair out. That's it. And most people feel absolutely no pain because we use really good topical anesthetics. So we've come a long way with anti-VEGF. I'm running a little short of time, so I'm going to just go a little bit faster. And we already talked about laser and steroids. Ozurdex is kind of cool. It's a steroid that is also implanted. It's a little tiny, a little rod that slowly also melts away and releases a little bit of steroid. It seems like these eyes just need like a little bit of constant treatment. So that's why these slow release pellets work really, really well in the eye. And there's a lot of move in that direction to have these slow release medications. So I'm going to skip Ozurdex because we're running a little long time. But here you can see, this is how we do. We inject into the eye this little tiny pellet, and it floats around in the periphery. A lot of times it gets lodged in the periphery so the patients don't see it, and it slowly releases drug. And again, we do this right in the office. You don't have to go to the operating room, and it's a really nice way to treat these patients. And Illuvium, as I was saying before, is this fluocinolone implant, and it lasts 24 months and actually even longer. And it's definitely a nice way to treat these eyes. Instead of getting constant treatment, a lot of times patients will be stabilized with this, with one injection for several years. And then again, this is the surgery. I tried to explain this to you earlier, but perhaps the picture helps. And you can see these are the little instruments that I'm putting in the eye. This is the light pipe, as I call it, and it illuminates the back of the eye so I can see well. And that's how I do my work. So with new treatments, what we're looking for is better efficacy, safety, and ease of treatment. And I'm doing some of this research. These are multi-center studies. This is a new class of drugs that we're looking at presently, Luminate, and they block different molecules. There are a lot of studies going on. Your doctor may suggest that you enter some of these studies. These are all controlled by the FDA, and usually they're in phase 3 studies, or phase 2 or phase 3. And they're targeting different molecules. And that's the idea, is maybe we can use these in conjunction with our present treatment, or maybe they'll be better and we can get rid of some of these treatments, or maybe they'll last longer so we can do fewer injections. So these are some of the molecules that we're looking at. Integrin is one. Luminate is its name. This is a current study that I'm doing. Excuse me. And this is interesting because it's actually given as a sub-Q injection. So not only will it help the eye, but it will actually help the whole body. So that's very interesting. So in summary, what's really important to know is get eye exams. Get it before you have symptoms, because we can pick up things, we start treatment earlier than you may think. And we have very successful treatment regimens. So it really is important to get to the doctor. The key is, of course, control your blood sugar. And it's not always easy to do that, but always that's your goal. That's where you're working towards. And better control means less treatment. Thank you.